Hello everyone, good evening everyone. So before I begin, I just want to say that anyone who's appearing for this FMGE June and July session, I wish you all the best. It probably might be the second or the third attempt of some of you. So I just want to say that it's okay, even if you had not cracked it in the first attempt. This time you will just go, before you go into the exam, say I can, I shall, I will, and you will definitely crack it. You will definitely score more than 150, hopefully more than 165. So you're eligible for INI-CT as well later in the later years, right? So don't be scared. Just revise the most important topics, the previous year questions. You have gotten done the theory. Just revise them and give your exam. You will be fine. You guys will be fine. All right. On that note, let's begin with the discussion of pediatrics, the most important topics. We'll first start with how the normal growth occurs. Frequently asked questions, simple one-liners are very frequently asked as far as your FMG exam is concerned, right? So let's start with weight. How the weight of the baby normally progresses. So we know when a baby is born, when an Indian baby is born, the average weight of a baby at birth is around 3 kgs. What's the weight? It's around 3 kgs. Let's consider this birth weight as X. Let's consider this birth weight as X, 3 kg, and at birth his birth weight is as X. By 5 months of age, the weight of the baby is going to double. The weight is going to become what? It's going to become 2x. So if the initial birth weight of the baby was 3 kg, he will now become 6 kg. By 1 year of age, this weight actually triples. You know, if your initial birth weight is 3 kg, it's now going to become 9 kg. By 1 year of age, the birth weight triples and baby now will weigh what? He will now weigh 9 kgs. By 2 years of age, it becomes 4 times the original birth weight. It becomes 4x. So if the initial birth weight was 3 kg, now it will become 3 into 4. That is, the baby will now weigh 12 kg. By 3 years of age, it becomes 5x. By 3 years of age, it becomes 5x. Baby will weigh 15 kg. By 5 years of age, it is 6x. By 5 years of age, it is 6x. Baby will weigh 18 kg. And by 7 years of age, the baby is 7 times the original birth weight. Baby is 7x. So original birth weight was 3 kg. 7 into 3, that is 21 kg. That is 21 kg. By the time the baby is 7 years of age, he will be 21 kg. So at birth, baby is 3 kgs. By 5 months of age, remember, this is very important, very frequently tested. By 5 months of age, the weight of the baby doubles. By 5 months of age, the weight of the baby doubles. By 1 year of age, the weight of the baby triples. Let's say originally the baby was 2.5 kg. By 5 months, he will become 2.5 into 2. 5 kg. By 1 year of age, it will become 2.5 into 3, that is 7.5 kg. So that's how the normal weight of the baby progresses. Now let's see how the length progresses. Now, at birth, the baby is approximately 50 centimeter in length. The length of the baby is approximately 50 centimeter. Now, in the first year of life, from birth to 1 year, baby will gain 25 centimeter in length. He will gain how much? He will gain 25 centimeter in length, so that at 1 year of age, the length of the baby will be 50 plus 25, that is 75 centimeter. That is 75 centimeter. Now, the next year, from 1 to 2 year, baby is going to gain half of what it gained in the first year. So in the first year, baby gained 25 centimeter. In the second year, baby will gain half of 25. That is 12.5 centimeter. So second year, baby gains around 12 to 13. We don't write 12.5, we write 12 to 13 centimeter. So that by 2 years of age, the length of the baby is 75 plus 12 or 75 plus 13. That is around 87 to 88 centimeter. Around 87 to 88 centimeter. Around 87 to 88 centimeter. Now for the next 2 years, from 2 to 4 years, baby is going to gain half of what it gained in the second year. So in the second year, baby gained 12 centimeter, 12 to 13 centimeter. Now it will gain 6 to 7 centimeter every year. Now it will gain 6 to 7 centimeter every year. So that at 4 years of age, so at 2 years, baby was 87. Add 7 centimeter to it. 87 plus 7 is 94. Add another 7 centimeter to it or 6 centimeter to it. 94 plus 7 or 94 plus 6 is round about 100 centimeter. So at 4 years of age, baby is finally 100 centimeter. If you look closely, this 100 centimeter is double of birth length. This 100 centimeter is 2 times the birth length, original birth length, right? Original birth length was 50 centimeter. Now the child is 100 centimeter. So as far as length is concerned, remember, it takes 4 long years to double your birth length. While as far as weight is concerned, it only took how much time? It only took 5 months. This tells you a very important property related to weight and length. Physiological property. Weight is something which is very fast. You know, if you are preparing for your exams, if you're staying home, you're drinking, let's say you're drinking Red Bull, Coke to stay awake, you're eating a lot, you'll rapidly gain weight. Exam gets done, you're happy, you go out, you go to the gym, you'll rapidly lose weight. Weight is something which you gain rapidly, lose rapidly. It is acute in nature. Well, as far as height is concerned, you can see here physiologically, height you gain slowly, you will lose slowly also. This is important when we'll discuss malnutrition. For acute malnutrition, you'll always prefer something which is weight-based. For chronic malnutrition, you'll always prefer something which is length or height-based, right? Now, after 4 years, baby will gain height at a rate of 6 centimeter per year. He will gain height at the rate of 6 centimeter per year till he reaches puberty, right? So at 4 years, he was 100 centimeter. What will be his height at 12 years? How many years have passed between 4 and 8? 4 and 12. How many years have passed between 4 and 12? 8 years have passed. 8 years have passed between 4 and 12. So how much height he would have gained? He was gaining height at 6 centimeter per year. He would have gained 8 into 6, that is 48 centimeters. So at 12 years of age, child will be roughly 100 plus 48, that is 148. If I want to write a whole number, he'll be approximately 150 centimeter. And if you look closely, this 150 centimeter is 3 times. It is 3 times the original birth length. So tripling of birth length is taking how much time? 12 years. While as far as weight was concerned, it took only 1 year. So let's write this down in simple one-liner format. Weight doubles in 5 months, triples in 1 year. While height doubles in 4 years, height doubles in 4 years and triples in 12 years and triples in 12 years. All right, and triples in 12 years. All right. Next we come to head circumference. Very important. When a baby is born at birth, the head circumference is 34 centimeter. At birth, the head circumference is 33 to 34 centimeter. Now, in the first 3 months, the baby gains head circumference at 0 to 3 months. Baby gains head circumference at 2 centimeter every month. He will gain head circumference at 2 centimeter per month. So the absolute head circumference increase will be 2 centimeter per month into 3 months. That is 6 centimeter. From 4 to 6 months, he will gain head circumference at 1 centimeter per month. So the absolute head circumference increase will be 1 centimeter for 3 months, another 3 centimeter. And from 7 to 12 months, he will gain head circumference at 0.5 centimeter per month. He will gain head circumference at 0.5 centimeter per month. So the absolute head circumference increase will be what? It will be 0.5 for 6 months. That is another 3 centimeter. So in the first year, from 0 to 12 months, he gained head circumference at 6 plus 3 plus 3. That is a total of 12 centimeter. He gained a total of 12 centimeter. He gained a total of what? He gained a total of 12 centimeter in the first year. So at birth, if his head circumference was 34 centimeter, at 1 year, it will be 34 plus 12 centimeter, that is 46 centimeter. At 1 year, his head circumference is going to be 46 centimeter. From 1 to 2 year, he gains additional 2 centimeter of head circumference. He will gain another 2 centimeter of head circumference, which is basically at 2 years, his head circumference is going to be, baby's head circumference is going to be 48 centimeter. Now, remember the adult head circumference, mine, yours, adult head circumference is 53 centimeter. It is 53 centimeter. If you do 90% of 53, it is 48 centimeter, 47.7. So can I say a child has already gained 90% of adult head circumference, which is 53 centimeter by 2 years of age, So child has already reached 90% of adult head circumference by what age? By 2 years of age. By 2 years of age, he has already reached 90%. So basically by 9, and what is head circumference? It's just a proxy for your brain growth. So it also means that 90% of your brain growth has also occurred by 2 years of age. Right? Very, very important. This has been asked as far as FMG is concerned. These growth curves have been asked in NEET PG and FMG. Right? Let's start with growth curves of important tissue. Which is this tissue? Like I said, 90% of the growth of this tissue has already occurred by 2 years of age. So this is basically your brain. Head circumference, 90% of head circumference, you already gain it by 2 years of age. So this is basically your brain or CNS. Alright, let's come to this tissue. What is this tissue? Right? This is a S-shaped pattern, also called as a sigmoid pattern, where there is an initial very fast uptick. Initially, it is going very rapidly. Initially, this is growing very rapidly. Then there is a plateau, and then there is another uptick around the time puberty starts. This is your height. As far as tissue is concerned, this will be your skeletal system or your somatic tissue, right? So remember height. Initial first year, 25 centimeter, 12 centimeter. Then I told you a plateau, 6 centimeter per year till puberty, and during puberty again you start have a growth spurt. We all know we have a growth spurt during puberty. So this is basically your height. As far as tissue is concerned, this is your somatic or skeletal tissue. Somatic or skeletal tissue. Alright, somatic or skeletal tissue. This is which tissue? This tissue, if you see, there is no growth in this tissue. This tissue is silent. There is zero growth till 10 years. And only after puberty does this tissue start to grow. This is basically your gonads. These are your gonads, your testes and ovaries. They're silent. They're not doing anything. They don't grow till puberty, and during puberty, they rapidly grow. This is your gonads. Once there was a question which was asked as far as FMG was concerned, that skeletal growth corresponds with, the answer was gonadal growth. Remember, the second spurt of the skeletal growth occurs when there is puberty, when there is gonadal growth. So this was once a one-liner asked in FMG. That skeletal growth corresponds to what? Corresponds to gonadal growth, right? They occur simultaneously, right? During puberty you have gonadal growth. During puberty you have your skeletal tissue or height growth as well, right? Then what is this tissue? The maximum growth of this tissue is occurring between 4 to 8 years. This is your Walder ring, your tonsils. This is your lymphoidal tissue. This is basically your lymphoidal tissue. All right. So this is how the normal growth of a person occurs. Now, how do you assess this growth? Growth can be assessed using age dependent or age independent parameters. Age dependent parameters, you need to know the age of the child, and for that age, whether the weight is appropriate, whether the length is appropriate, whether let's say the child has 12 kg weight, whether this 12 kg is appropriate for 2 years, yes. But if there is 12 kg for 5 years, no. 12 kg for 5 years will not be appropriate. You need to know the age of the child. So these are called age dependent parameters, right, for assessing growth. These include your weight for age. These include your height for age, head circumference for age. Then you have certain age independent parameters where you don't need to know the age of the child. They will usually have cutoffs. Iske upar hai, if it is above a cutoff, you will say child is normal. Below a cutoff, you will say child is abnormal. Child is malnourished, right? These parameters include your weight for length. See, in weight for length, there is no age. For that particular length, 90 centimeter length, what is an appropriate weight? For 100 centimeter length, what is an appropriate weight? You don't need to know the exact age of the child. So weight for length is age independent. It is age independent. Another very important age independent parameter frequently tested is mid-upper arm circumference, MUAC, and something called as skin fold thickness. Both of them are frequently tested. All right. Now, till now I've used the term height or length interchangeably, but they don't mean the same. When I say the word height means standing height. When someone is standing, that's what you measure is called standing height. So height refers to standing height. Remember, height refers to standing height. It's only taken in children when you are able to stand. It's usually taken in children more than 2 years, and it's measured using this instrument. This instrument is called standing height. So instrument is called stadiometer. Instrument is called as what? It's called as instrument is called as stadiometer. While as far as length is concerned, it is measured in children less than 2 years using this instrument. What is this instrument called as? See, less than 1 year, a child is called infant. So this instrument where you are measuring the length, right? When the child is lying supine, that's length. L for length, L for lying supine. When you're lying supine and that's what you measure is called length. This is measured using an instrument called as infantometer. This instrument is called as infantometer. Next we come to mid-upper arm circumference. So where do you measure the mid-upper arm circumference? If this is my upper arm, where do you measure it? Here there is an acromion process, here there is an olecranon process. So midpoint between the acromion and olecranon process, that's where you measure the mid-upper arm circumference. So it's measured where? It's measured between the midpoint between the acromion and olecranon process. That's where we measure the mid-upper arm circumference. Now, what is the importance of mid-upper arm circumference? Like I told you, it's an age-independent parameter. So you don't need to know the age of the child. If it is above a cutoff, you'll say child is normal. If it's below a cutoff, you'll say child is abnormal. So what are these cutoffs? These are in some centimeters. You will measure here, the value will come in centimeter. So if it is above 12.5 centimeter, if this mid-upper arm circumference is above 12.5 centimeter, you'll say child is normal. If this mid-upper arm circumference is between 11.5 centimeter to 12.5 centimeter, you'll say child is borderline. Borderline in terms of his nutritional status. And if this mid-upper arm circumference is less than 11.5 centimeter, you'll say child is having SAM. What is SAM? SAM is severe acute malnutrition. So anytime the mid-upper arm circumference is less than 11.5 centimeter, you'll say child is having what? Child is having SAM. It's measured using this tape. What is the name of this tape? This is called as, I hope you all know this, is called as Shakir tape or Shakir's tape. And if you look closely, the Shakir tape is color coded. I told you above 12.5 centimeter is normal. So you see above 12.5 centimeter, Shakir's tape is green. Anytime the mid-upper arm circumference is more than 12.5 centimeter, Shakir's tape is green. Between 11.5 to 12.5 centimeter, between 11.5 to 12.5 centimeter, you can see the Shakir tape is yellow when the child is borderline, and you can see Shakir's tape is red anytime the mid upper arm circumference is less than 11.5 centimeter. So this is used to measure the mid upper arm circumference between the acromion and the olecranon process. Another thing that you can do is skin fold thickness. What is skin fold thickness? This here is skin fold thickness. Here you can measure skin fold thickness. Here you can measure skin fold thickness, right? Again, it is age independent. Again, skin fold thickness, remember, is age independent. It's measured using this. The name of this instrument, this is called as a Harpenden caliper. This is called as the Harpenden's caliper. Now, if the skin fold thickness is less than 6 mm, you say the child is malnourished. If the skin fold thickness is more than 10 mm, you will say the child is normal. So obviously between 6 to 10 mm, borderline. Where do you measure the skin fold thickness? Remember, the most common site is triceps, and this has been asked. Other sites include your biceps and between your scapula. So biceps and back, or between the scapula. These are the other sites where you can measure this skin fold thickness, All right. Now we come to another very important topic, which is an integration between biochemistry and biochemistry and your pediatrics. It is your vitamins and minerals. So we know that vitamins are divided into two categories: fat-soluble and water-soluble. Fat-soluble are soluble in fat. As a result, they can be stored in the body. Where are they stored? They are stored in liver. They are stored in liver. And because they can be stored, you can have symptoms of excess, right? Excess can be occurring, right? Excess can occur, hypervitaminosis can occur. Well, water-soluble vitamins, because they are water-soluble, they are excreted in urine. They are not stored in the body. And there will never be any excess. There will not be any excess of them. There's only one water-soluble vitamin which is stored in the body. Can anyone tell me that? It is vitamin B12. Remember, one exception exists. Vitamin B12 is stored in liver. Rest everyone is excreted in the urine. It's not stored in the body. Now we first start with water-soluble vitamins. What will happen if there is a deficiency? So we first have vitamin B1. Vitamin B1 is thiamine. We all know its deficiency leads to what? Its deficiency leads to beriberi. What's the main function of thiamine in the body? Remember, it's important for your TCA cycle. And what happens in beriberi? There are two types of beriberi. See, vitamin B1 is important for TCA cycle. TCA cycle is important for energy generation, ATP synthesis. So if there is beriberi, the ATP is not getting formed. If ATP is not getting formed, energy is not there. If energy is not there, which are the two most important organs which require a lot of energy, a lot of ATP in a body? It's your dil and dimag, your heart and your brain. So these are the organs which get affected in beriberi. You can have two types of beriberi. You can have wet beriberi, you can have dry beriberi. If the heart is affected, you end up having wet beriberi. In wet beriberi, you have what? You end up having high output cardiac failure. You end up having high output heart failure. So if there is heart failure, you'll end up having edema, and that's why if there is high output heart failure, you'll end up having edema, and that's why it's called wet beriberi. In dry beriberi, your nervous system is affected, you'll end up having neuropathy. Next, you have riboflavin. The deficiency of riboflavin is important for FAD and FADH2. Where it is used for FAD and FADH2, right? And its deficiency very characteristically leads to angular colitis. It leads to a lot of inflammation around the mouth. So you can have mouth ulcers, you can have stomatitis, you can have inflammation of the tongue, and very characteristically you have this angular colitis. You can also have this. What is this? You can see new blood vessels going into the cornea. Corneal neovascularization. So deficiency of vitamin B2 can also lead to corneal neovascularization. Next, you have niacin. Niacin is very important, very frequently tested in FMGE, especially the deficiency of niacin. Now, one important thing as far as niacin, you have to understand that niacin, actually, even if you don't take adequately in the diet, our body can make niacin from tryptophan. In our body, you can actually use tryptophan to make niacin. 60 mg of tryptophan can get converted into 1 mg of niacin in our body. The conversion of the tryptophan into niacin, this pathway is called kynurenine pathway. What is the name of this pathway? It's called kynurenine pathway. It's called as kynurin pathway, and this pathway requires vitamin B6 as a cofactor. So our body can actually make niacin not from diet, we can actually make it from tryptophan as well. We can make it from tryptophan as well. Whenever there is niacin deficiency, we all know it leads to what? It leads to pellagra. It leads to what? It leads to pellagra. What are the 3 Ds of pellagra? I hope everyone knows them. It is diarrhea, dementia, and dermatitis. It is what? Diarrhea, dementia, and dermatitis. It is diarrhea, dementia, and dermatitis. If you look at the dermatitis very frequently, this is a very common image given in your FMGE exam, very commonly tested image in your FMGE exam. Look at the dermatitis characteristically. You can, if you look closely, you can see that this person was probably wearing what? He was probably wearing a banyan. Look here. He was wearing a banyan, and where he was wearing that vest and banyan, this area, this entire chest, completely normal. This is completely normal. There is no dermatitis. Where is the dermatitis? Dermatitis is on the hands. There is the dermatitis. Here is the dermatitis. Dermatitis is here. Why is the dermatitis over here and not on here? Because he was wearing a vest. This protected the skin from the sun. So can I say the dermatitis which occurs in pellagra is sun exposed? It worsens in sun. Right? So dermatitis occurs in sun exposed areas. Where does it occur? It occurs in sun exposed area as far as your niacin deficiency and pellagra is concerned. And the dermatitis which occurs over neck is like a necklace. This is called as known as Castle's necklace. This is known as Castle's necklace. Again, very frequently tested. Again, very frequently tested. Again, very frequently tested. Okay, I'll go slow. I'll go a little slow. This is basically a revision class, so that's why I was going a little fast. Don't worry, you will get the PDF. If you're trying to write it down, obviously it's going to be a little fast. You'll get the PDF. Don't worry about the PDF, right? You will get the PDF. You will definitely get the PDF. You will definitely get the PDF. Don't try to write it down. Just try to revise. This is the revision session of the most important high yield topics. Tell me, if you're not able to understand, I'll definitely go slow. If you are trying to write it down and that's why you're feeling it is fast, then don't worry. Just listen to this 1.5 hours, not 1.5 hours, around 2 hour session, and you'll be perfectly fine. You will be perfectly fine. All right. You'll be perfectly fine. All right. You'll be perfectly fine. All right. Don't try to write it down because you'll get the PDF anyway. And you can use this PDF to revise for the last 1 to 2 days, last 1 week. So don't worry about that. Okay. Don't worry about that. All right. Harsh is saying the speed is fine. No, Harsh, you have to make the speed not for you, for the person who's not able to understand. So if someone asks me to go slow, I have to go slow. So I'm again asking Reza. I'm again asking Reza that if you're trying to write it down, you will find it fast, but don't worry, you'll get the PDF. We'll give you the link of the WhatsApp group. You can join the WhatsApp group. You'll get the PDF. So don't worry about the PDF part, right? Don't worry about the PDF, the writing part. All right. Try to use it as a revision session. All right. Try to use it as a revision, fast-paced revision session. Okay. All right. Now, like I was going as far as niacin was concerned, remember, like I said, niacin, you can actually, deficiency of niacin leads to what? It leads to pellagra. There are 3 Ds of pellagra: diarrhea, dementia, and dermatitis. You will have diarrhea, you will have brain problems, you will have dementia, you will have dermatitis, and dermatitis, it occurs in the sun exposed area. So it's occurring on the hand, it's occurring over the neck, and the dermatitis over the neck is called as Castle's necklace. It's called as Castle's necklace. And you can make niacin from tryptophan. Now this brings about a very important property as far as niacin deficiency is concerned. Let's say there is a scenario, let's say there is some disease in the body where there is no tryptophan in the body. You don't have a problem with niacin, you don't have tryptophan in the body. If there is no tryptophan, that's what's going to occur. If there is no adequate tryptophan, again, you'll not have adequate niacin. And if you don't have adequate niacin, you'll end up having what? You'll end up having pellagra. So you have to understand that pellagra in our body can occur because of niacin deficiency. It can also occur because of tryptophan deficiency. Remember, pellagra in our body can occur because of lack of tryptophan as well, because lack of tryptophan will lead to lack of niacin. Therefore, pellagra can also occur. Because of tryptophan deficiency. It can also occur because of tryptophan deficiency. Now, what are the diseases which cause pellagra because of tryptophan deficiency? There are 3 main examples you should remember. First is what is called as the Hartnup disease. Hartnup disease, it's a genetic disorder. It is an autosomal recessive genetic disorder where there is a defect, where there is an absence of neutral amino acid transporter. There is an absence of neutral amino acid transporter. In the gut. Where? In the gut. So your body doesn't absorb any neutral amino acid. It doesn't absorb any tryptophan and other neutral amino acid, valine, leucine, glycine, other neutral amino acid, they are also not absorbed. But because tryptophan is not absorbed, so like I said, if there is no tryptophan, there will be no niacin. And if there is no niacin, you'll end up having pellagra. So these individuals who have this heart nerve disease, they'll present with what? They'll present with pellagra. They'll present with diarrhea, dementia, and dermatitis. They'll present with diarrhea, dementia, and dermatitis. The second thing that can lead to pellagra is a maize-rich, very important, maize. Maize is what? Corn, right? Maize-rich diet. Again, this has been asked very frequently in FMG. Now, what is the problem with maize-rich diet? Maize doesn't contain any tryptophan. There is low tryptophan in maize, and maize actually contains a very high amount of leucine. Maize has a very high amount of this leucine. Now, what's the problem with this high amount of leucine? This leucine is known to inhibit the kynurenine pathway. It's known to inhibit the kynurenine pathway. So you're not taking adequate tryptophan. That is one problem. On top of that, the leucine will ensure whatever tryptophan is there, it is not converted into niacin because the kynurenine pathway is, because this pathway which I told you, this kynurenine pathway itself is inhibited. All right. The third thing that can cause pellagra is serotonin syndrome. Why? See, tryptophan in a body, it is used to make niacin. I told you right now. It is also used to make serotonin. In serotonin syndrome, what is going to occur? All the tryptophan which is available in the body, it's going to get diverted towards making serotonin. So there will be no tryptophan left to make niacin. So again niacin deficiency, again pellagra. Again niacin deficiency, again pellagra. Okay, so this is very, very important. These three things, heart nerve disease, maize-rich diet, serotonin syndrome, can lead to pellagra, is very frequently asked in your FMG exam. All right, and I told you why it occurs. Heart nerve disease, no tryptophan absorption, lack of neutral amino acid transporter, genetic disorder, inherited in autosomal recessive manner. So they'll give you history of disease in the siblings. They might give you history of disease in the parents or something like that. Maize-rich diet, high amounts of leucine, doesn't allow the kynurenine pathway, and low tryptophan. And serotonin syndrome, all the tryptophan is diverted towards making serotonin, so nothing is left to make niacin. Next we have pantothenic acid. Deficiency of pantothenic acid, remember, causes burning foot syndrome. It causes burning foot syndrome, a lot of dermatitis, and this dermatitis is very painful. It causes burning foot syndrome. You have vitamin B6. Remember, the main function of vitamin B6 in the body is decarboxylation. It is decarboxylation. It helps in decarboxylation in our body. It's also part of ALT and AST, your liver enzymes, ALT and AST. It also helps in heme synthesis. It also helps in making your heme. So its deficiency, very characteristically, deficiency of pyridoxine is known to cause peripheral neuropathy. It's known to cause what? It is known to cause peripheral neuropathy in adults, in older children and in adults. And in newborns, very important, in newborns, it can cause refractory seizures. Its deficiency can cause what? It can cause refractory seizures. All right. And because heme is not formed, if there is pyridoxine deficiency, heme is not formed. So hemoglobin is not formed. This anemia where heme is not formed, so all the iron will be deposited in the RBC. You will have iron-laden RBCs. This is called sideroblastic anemia. So you can have sideroblastic anemia. You can have sideroblastic anemia as far as pyridoxine deficiency is concerned. Next you have biotin. Remember, B6 was decarboxylation. Biotin is carboxylation. It's important for all the carboxylases and carboxylation reactions in the body. So it's important for all the carboxylation reactions in the body. And deficiency of biotin very characteristically causes alopecia. Again, very frequently tested. Alopecia occurs because of which vitamin deficiency? The answer is going to be biotin. All right. And when does biotin deficiency occur? It occurs in individuals who have a diet which has a lot of raw white egg. When does deficiency occur? If you take a diet rich in raw white eggs, because this raw white eggs contain avidin, and avidin is known to inhibit biotin absorption. So if you take a diet which has a lot of raw white egg will contain avidin. It will not allow the biotin in the diet to be absorbed. No biotin, biotin deficiency, alopecia. Next you have folate and vitamin B12 deficiency. We all know folate and vitamin B12 deficiency leads to megaloblastic anemia. It leads to megaloblastic anemia, where there will be what kind of RBCs? Very big RBC. You will have macrocytosis, you will have increase in MCV, you will have macrocytosis, and very characteristically, you will see these kind of neutrophils, 1, 2, 3, 4, 5, 6. More than 6 lobes in neutrophil. Normally, neutrophils have 2 to 4 lobes, but here you will see lobes 6, 7, 8. Such kind of neutrophils are called as hypersegmented neutrophils. Such kind of neutrophils are called as hypersegmented neutrophils, which you will see in megaloblastic anemia. Remember, as far as folate deficiency is concerned, folate deficiency will cause only anemia. While as far as vitamin B12 deficiency is concerned, you will have anemia along with certain central nervous system changes. You will have subacute combined degeneration. That's a medicine topic, but write it down here also. Vitamin B12 deficiency will cause anemia along with CNS changes. And another important thing related to vitamin B12, you should remember that vitamin B12 is found only in animal sources. So vegetarians and vegans are at a very high risk of having vitamin B12 deficiency. So vitamin B12 is found only in animal sources, only in animal sources. So that's why vegetarian and vegans are at a risk of having vitamin B12 deficiency. Vitamin B12 deficiency. Next water-soluble vitamin is your vitamin C, which is basically your ascorbic acid. Which is basically your ascorbic acid, What is the main function of vitamin C in our body? Collagen synthesis. It helps in hydroxylation of lysine and proline in collagen. It helps in hydroxylation of lysine and proline in collagen. So it makes the collagen more active, an active form of collagen, which is able to do its function, right? Hydroxylation of lysine and proline in collagen. So if obviously vitamin C is deficient, proper collagen is not formed, and that will lead to all its deficiency symptoms. It's also a very important antioxidant. It's a very important antioxidant, and it helps in absorption of iron. It helps in absorption of iron because it converts Fe3 plus to Fe2 plus. And that's how it helps in absorption of iron. What does vitamin C deficiency leads to? It leads to, we all know, it leads to scurvy. So what will happen in scurvy? You will have no collagen, right? This hydroxylation of lysine and proline in collagen. In scurvy, what is going to occur? This thing is not going to occur. In scurvy, this thing is not going to occur. So you will not have proper collagen. Where is collagen? Collagen is there in gums. If you don't have collagen in gums, the gums will start to bleed. So have this, you will have bleeding gums. You will have what? You will have bleeding gums. You will have bleeding gums. You will have bleeding in joints as well. You will have bleeding gums. You will have bleeding joints. This bleeding joints will lead to very painful joints. These will be very, very painful. This will be very painful, which can lead to child not able to stand. This is called pseudo paralysis because of the painful joints. If your knees are very painful, the child will have difficulty in standing because of the painful joints. If he doesn't stand, it will appear like paralysis. Obviously, it's not paralysis, it's just painful joints. This is called as pseudo paralysis. So this painful joints can even lead to pseudo paralysis. They can even lead to what? They can even lead to pseudo paralysis. They can even lead to what? They can lead to pseudo paralysis. You have problems in your ribs also. Ribs will also start to have, these are bone, they will have a lot of collagen. If there's no collagen, they will be bleeding in the ribs as well. This will lead to formation of this kind of structure. You will have these bead-like structure. This is nothing but bleeding inside the ribs. This is nothing but subperiosteal hemorrhage. And this is called as corbitic rosary. This is called as corbitic rosary, bleeding inside the ribs, leading to this bead-like formation. And obviously this corbitic rosary will be very painful. If you touch, it will be very painful. It will be very tender. It will be very painful and it will be very, very tender. It will be painful and tender. What are the X-ray changes that you will see? 3 things you should remember. So one thing that you see is you will see a white line of Frankel. This at the end of the bones, you will see excessive calcification. It's also called dense zone of calcification. It is also called dense zone of calcification. Because of lack of collagen, the epiphyses will assume a ring shaped. Normally the epiphyses are going to be like this, but here they will assume a ring shaped structure. This is called as Wimberger's ring sign. It's called as Wimberger's ring sign, and there will be sideways growth, which is called as Pelkin spur or Pelkin fracture, because again there is no collagen. These are 3 things you should remember. The most important thing you can remember is towards the end of metaphysis, towards the end of the bones, you will see excessive calcification. This is called as white line of Frankel or dense zone of calcification. Dense zone of calcification. This is what you see in X-ray. Now we come to the fat-soluble vitamins. We first start with vitamin A. We first start with what? We first start with vitamin A. Now, what happens as far as vitamin A is concerned? Deficiency of vitamin A. Deficiency of vitamin A, we all know, leads to xerophthalmia. It leads to what? Dry eyes. Xerophthalmia. What is the main function of vitamin A in a body? It helps in maintaining epithelial integrity, maintains the epithelial function, integrity and differentiation. It's also important for vision, and it's important for cell-mediated immunity. It's also important for cell-mediated immunity. It's also important for cell-mediated immunity. Now, deficiency of vitamin A, because there is no epithelial integrity, the skin will lose moisture, skin will become dry. This is called as phrinoderma. You can also have something called as phrinoderma. Phrinoderma is a dry skin like toad, a toad-like dry skin. The skin will lose all the moisture because the epithelial integrity is not there, the epithelium is not proper, so it loses moisture, skin becomes very, very dry. This is called toad-like dry skin. Whenever drying of your eyes, it's called xerophthalmia, right? So the eye manifestation of vitamin A deficiency is xerophthalmia. What is the WHO classification of xerophthalmia? Very, very important. Very frequently tested. So first thing that you see as far as eyes are concerned, as far as signs are concerned, the first thing you will see drying of conjunctiva. So first sign, remember, always remember, the first sign of vitamin A deficiency is conjunctival xerosis, drying of conjunctiva. It is conjunctival xerosis. It is conjunctival xerosis. What is the first symptom? What do you mean by symptom? What is the first symptom? First symptom refers to what the child tells you because of vitamin A deficiency. Remember, the first symptom is always night blindness. It is night blindness. I'm writing NB for short. It is night blindness. And this has been asked in the last FMG itself. What is the first sign of vitamin A deficiency as far as eyes are concerned? Sign is what the doctor sees. So first thing you will see dry eyes. You will see drying of conjunctiva. It is conjunctival cirrhosis. What will the patient tell you first? What is the first symptom? It is night blindness. After X1A, after the first X1A, the first sign X1A, next sign is B, X1B. B stands for Bitot spots. It stands for Bitot spots. The conjunctiva, because it becomes dry, it starts to coagulate and it will form Bitot spots on conjunctiva. After conjunctiva, cornea will become dry. So X2 is corneal xerosis. X2 is corneal xerosis. After cornea becomes dry, cornea will start to ulcerate. So X3 is corneal ulceration. Depending upon the surface area, you can have X3A or X3B. X3A is a corneal ulcer. X3A is a corneal ulcer involving less than 1/3 of the total surface area. X3B is a corneal ulcer involving more than 1/3 of the total surface area. What will be the treatment of vitamin A deficiency? You need to give vitamin A. Remember, it's a medical emergency because the child can become blind. So you'll give vitamin A on day 0, day 1 and day 14. On that day itself, next day and 2 weeks later. The dose will be dependent upon the weight of the age of the child. Child is less than 6 months, you will give 50,000 international units. Between 6 to 12 months, you will give 1 lakh international units. Child is more than 12 months, you will give 2 lakh international units. You'll give this, for example, let's say there is a 9-month-old child. Let's say there is a 9-month-old child, right? Between 6 to 12 months. You'll give 1 lakh on day 0, you'll give 1 lakh on day 1, and you'll give 1 lakh on day 14. Again, the dose also has been asked as far as your FMG exam is concerned. Dose also has been asked as far as the FMG exam is concerned. Next, we come to vitamin D. So we all know vitamin D is important for, mineralization of bones. What is the main function? It helps in mineralization. Deposition of calcium and phosphate in the bones, making bones healthy. Deficiency, we all know, leads to what? Deficiency of vitamin D leads to rickets. What do you see in rickets? What do you see in rickets? You will see these things. What are these things called as? These are lower limb changes. These are lower limb changes that you will see. This is called as knock knees. The knees are knocking each other. This is called as knock knees. Also known as genu. Knees are knocking each other. They are joined together. Gum helps in joining stuff together. This is also known as genu valgum. You can have knees like this, like a bow. You can have knees like this, like a bow. These are called as bow legs. Also known as genu varum. Or you can have this. It's almost like there is a wind coming and which has swept the knees like this. This is called wind swept deformity. It's called as wind swept deformity. Alright. So these are the lower limb changes that you will see. In chest, what you can see? You can see something rosary. Again, you can see this bead-like formation. Again, you can see this bead-like formation. This is called rachitic rosary. This is called as what? This is called as rachitic rosary. Now, this, remember I told you vitamin C, scorbutic rosary, it occurs because of bleeding. This doesn't occur because of bleeding. It occurs because of expansion of cartilage because it is not getting calcified. It occurs because of expansion of costochondral junction cartilage. This occurs because of expansion of costochondral junction cartilage. It occurs because of expansion of costochondral junction cartilage. You can also see these things. You can see this. This is called pigeon chest, pectus carinatum. The chest will become like this. The ribs will start to, instead of being like this, they'll start to become like a pigeon's chest. This is called as pigeon's chest or pectus carinatum. And you'll start seeing depression here because the ribs don't have any integrity. As soon as you take a deep breath, the chest wall will collapse inwards. So this depression that you see here, is called Harrison sulcus. It's called Harrison sulcus. It's called as Harrison. This is called as Harrison sulcus. All right. What do you see on X-ray? You'll see that at the end of the bone, there is no calcification. This results in this cup-shaped structure. This is called cupping. Calcification can be a little patchy. This is called fraying. And then you will have sideways growth. This is called as splaying. So you see three things together. You see cupping, splaying, and fraying. You'll see cupping, splaying, and fraying. But remember, the first sign is not cupping, splaying, and fraying. The first sign is actually loss of calcification because there is no vitamin D, no calcium will get deposited. That's the first sign on X-ray. There is loss of calcification. There is loss of provisional zone of calcification. That is the first sign as far as X-ray changes is concerned. That is the first sign as far as X-ray changes are concerned. All right. Now, this is a very important image that I wanted to tell you. What is this? Very frequently, this image is being asked again and again in FMG. What is this? What is this image telling you? What is this image telling you? If you're watching this, let me know. What is this image telling you? Fraying, remember, fraying is not earliest to appear. I don't know who told you though. Remember, the first thing to appear is loss of provisional zone of calcification. It is loss of provisional zone of calcification. Cupping, splaying, and fraying don't occur in, they are the later signs. The first thing to occur in rickets is loss of provisional zone of calcification. Remember that. What is this? What is this? Zinc deficiency. Yes, but what is this called as? What is this called as? Someone wrote acro. Yes, yes. This is acrodermatitis enteropathica. Exactly. This is acrodermatitis enteropathica. This is acrodermatitis enteropathica. Why does it occur? Why does it occur? It's actually a genetic disorder. It's an autosomal recessive disorder which occurs because of SLC39A4 mutation. And because of this mutation, there's absence of zinc absorption. This is a zinc channel. It helps in absorption of zinc. So this is an autosomal recessive disorder where there is no zinc absorption leading to zinc deficiency. And what does it cause? It causes acrodermatitis. There is dermatitis around the acral areas. There is dermatitis where? There is dermatitis in acral areas. What are the acral areas? The extremities. What do you mean by acral areas? The mouth, the hands, the anus. These are the acral or the extremities areas, right? See dermatitis around that. Along with that, what is the enteropathic part? You will see a lot of diarrhea. You will see a lot of diarrhea. You will see a lot of what? You will see a lot of diarrhea. So that's why it's called as acrodermatitis. Dermatitis in the acral regions along with enteropathica, along with diarrhea. This is what you will see as far as zinc deficiency or acrodermatitis enteropathica is seen. Along with that, remember, what will selenium deficiency cause? What will selenium deficiency cause? Can anyone tell me what will selenium deficiency cause? What will selenium deficiency cause? What will selenium deficiency cause? Can anyone tell me what will selenium deficiency cause? Exactly. Keshan's what? Keshan's what? It causes Keshan's cardiomyopathy. So always remember, selenium deficiency can lead to what? It can lead to Keshan's cardiomyopathy. It can cause heart problems, it can cause heart failure, again lead to edema and everything. Right? So it can cause Keshan's cardiomyopathy. It can cause Keshan's cardiomyopathy. It can cause Keshan's myopathy. Copper deficiency is seen in which genetic disorder? Copper deficiency is seen in which genetic disorder? Copper deficiency is seen in which genetic disorder? Exactly. It's seen in Menkes disease. Very important. Very good. Very good. Very good. It's seen in Menkes disease. It's seen in Menkes disease. It's an X-linked recessive disorder. Remember, it's an X-linked recessive disorder. Occurs because of ATP7A mutation. Occurs because of ATP7A mutation. It occurs because of ATP7A mutation. And it very characteristically has copper deficiency along with kinky and curly hair. Along with kinky or curly hair. So this is a very characteristic finding. They will give you an exam. They will give you a child has kinky hair, curly hair along with copper deficiency. What's the diagnosis? Answer is going to be Menkes disease. Answer is going to be Menkes disease. Answer is going to be Menkes disease. All right. Now, next we come to malnutrition. So I already told you that weight is something which is acute. Height is something which is chronic. So as far as acute malnutrition is concerned, remember we judge it using, it is assessed using which parameter? It is assessed using weight for length. It is assessed using weight for length. It is assessed using weight for length. While chronic malnutrition is assessed using height for age. It is assessed using what? It is assessed using height for age. It's assessed using height for age. Now remember, it's a biostats concept, it's a PSM concept that between +2 standard deviation to -2 standard deviation, between +2 standard deviation to -2 standard deviation, everything is considered normal. Between +2 and -2 standard deviation, everything in medicine is considered normal. Anytime anything becomes more than +2 standard deviation, you call it abnormal. Anytime anything is less than -2 standard deviation, you call it abnormal. Right? Remember, between +2 and -2 standard deviation, everything in medicine is considered normal. Everything in medicine is considered normal. That's considered normal range. 95% population is in this range. Anything above +2 standard deviation is abnormal. Anything less than -2 standard deviation is abnormal. So when do you call it acute malnutrition? You call it acute malnutrition only when the weight for length is less than -2 standard deviation. If it is in +2 and -2 standard deviation, it is normal. When the weight for length is less than -2 standard deviation and between -2 to -3 standard deviation, it is moderate acute malnutrition. It is moderate. It is called as moderate acute malnutrition. It's called as moderate acute malnutrition. When the weight for length becomes less than -3 standard deviation, even lower, becomes lower than -3 standard deviation, it is called as severe acute malnutrition. It is called as severe acute malnutrition. There is no mild acute malnutrition. Anytime weight for length is less than -2 standard deviation. So what is the definition of acute malnutrition? Anytime the weight for length is less than -2 standard deviation, it becomes automatically becomes acute malnutrition. If it is in -2 to -3, it is moderate acute malnutrition. It is less than -3, it is severe acute malnutrition. It is severe acute malnutrition. Remember, acute malnutrition is also known as wasting. Another term for acute malnutrition is wasting. So let's say the weight for length is -2.5. Weight for length is -2.5 standard deviation. You can call it moderate acute malnutrition. You can also call it moderate wasting, because acute malnutrition is equal to wasting. If let's say weight for length is -3.5, you can call it as severe acute malnutrition. You can also call it as severe wasting. Similarly, as far as height for age is concerned, between +2 and -2 standard deviation, height for age is normal. So what is chronic malnutrition? Only when height for age falls less than -2 standard deviation. Severity wise, again, it will be same. So if the height for age is less than -2 standard deviation, you will call it as moderate chronic malnutrition now. If the height for age is less than -3 standard deviation, now you will call it as severe chronic malnutrition. Now you will call it as what? You will call it as severe chronic malnutrition. We'll call it as severe chronic. Remember, chronic malnutrition is also known as what? It is also known as stunting. Okay, it is also known as stunting. Very good. Wow. Vani OS has done it perfectly, right? If height for age is less than -2 standard deviation, it is chronic malnutrition or stunting. If weight for length is less than -2 standard deviation, it is acute malnutrition or wasting. There's another parameter which I did not discuss, which is weight for age. Now the good thing and the bad thing about weight for age is the same. The good thing is it can be used for both acute and chronic malnutrition. Now, because it can be used for both acute and chronic malnutrition, there is no specificity. If weight for age is low, you as someone who's assessing the child don't know whether it is acute malnutrition, don't know whether it is chronic malnutrition. So when weight for age is low, we don't use the term acute or chronic malnutrition. We don't say the child is wasted or stunted. We use a third different term. So whenever the weight for age is low, whenever the weight for age is less than -2 standard deviation, we say the child is underweight. We say the child is underweight. Remember, we never use acute or chronic malnutrition term with low weight for age, because you as a pediatrician doesn't know whether the weight for age has become low because of acute malnutrition or chronic malnutrition, because weight for age can be low in both. It can be low in both. So we never use the term. Very important. We never use the term acute or chronic malnutrition with low weight for age. Whenever the weight for age is low, we simply call the child as what? We simply say the child is underweight. Alright, very important. I'll give you an example. Let's say there is a child, there is a 2-year-old child who has come to you. His weight for age is -2.7 standard deviation. His weight for length is -1.1 standard deviation. His height for age is -2.7 standard deviation. Child has A, acute malnutrition, B, stunting, C, severe acute malnutrition, D, normal child. What will be the answer? What will be the answer to this question? So Harsh is saying moderate chronic malnutrition. That's not in the option. What's the answer? Exactly, it's going to be B, stunting. See, weight for age is minus 2.7 means child is underweight. If someone is underweight, we don't know whether it is acute or chronic malnutrition. So we won't comment on that. Weight for length is normal. So child doesn't have acute malnutrition. If weight for length is normal, it obviously means child doesn't have acute malnutrition. So I can rule out acute malnutrition, I can rule out SAM. If height for age is minus 2.7, like someone rightly pointed out, it is moderate chronic malnutrition, or this is moderate stunting, The answer is going to be stunting. Answer is going to be child stunting. This is not a normal child. So this is how you solve the question. Independently write down the parameters, right? But remember, weight for age is not used for, never use the term weight for age, low weight for age for acute or chronic malnutrition. Because whenever the weight for age is low, it can be low in both acute and chronic. So you don't know. So specifically for acute malnutrition, you have weight for length. For chronic malnutrition, you have height for age. Now coming to the two very important forms of, most severe forms of protein energy malnutrition, which is Kwashiorkor and Marasmus. Now a lot of people have a very common misconception that Kwashiorkor is protein deficiency, Marasmus is calorie deficiency. That's a wrong concept. You have to understand, in both Kwashiorkor and Marasmus, the body loses protein. There is protein loss in both of them. The only difference between Kwashiorkor and Marasmus is from where the body loses protein. There are two distinct protein compartments in our body. There is a somatic protein compartment. There is a visceral protein compartment. By somatic protein compartment, I mean the protein which is there in your muscles. So if you lose protein in your muscles, you will end up having what? You will end up having Marasmus. The visceral protein compartment is the protein which is there in your albumin. Protein which is in there, your enzymes, neurotransmitter. If you lose albumin, neurotransmitter, enzymes, you'll become lethargic. You lose albumin, you'll become edematous. You'll end up having, facial edema and everything. That's what we call as Kwashiorkor. So Kwashiorkor is loss of which protein? Visceral protein. Marasmus is loss of which protein? Muscle protein or somatic protein. So Kwashiorkor is loss of visceral protein, while Marasmus is loss of muscle or somatic protein. But in Marasmus, you preserve visceral protein. Visceral protein is preserved. Albumin is preserved. You lose albumin, neurotransmitters. What is visceral protein? It is basically your albumin, neurotransmitter, enzymes as far as Kwashiorkor is concerned. So how do these children look like? They look like this. In Kwashiorkor, because you have lost albumin, what will happen? You'll have a lot of edema. So edema over face will cause round face. This is called as moon faces. You'll have edema on the abdomen. This is called bulging abdomen or ascites. In Marasmus, you lose muscle mass. There is loss of muscle mass. You lose muscle over here. You lose buccal pad of fat. Face becomes like this. This is monkey-like or simian faces. This is what's called as monkey-like or simian faces. If you lose muscle over, you'll lose gluteus maximus. Gluteus maximus is the muscle. The buttocks is the muscle. If you lose your gluteus maximus, the skin over your buttocks will start to hang. Because there is no muscle underneath, the skin will hang. This is called baggy pant appearance. So Marasmus will have what? Marasmus will have baggy pant. It will have a baggy pant appearance. So what are the difference between Kwashiorkor and Marasmus? In Kwashiorkor, there is visceral protein wasting. Here there is somatic or muscle protein wasting. Because you lose your neurotransmitter and your enzymes. If you don't have your enzymes, you don't have neurotransmitters. If you don't have any neurotransmitters, you'll become lethargic. So Kwashiorkor child is lethargic. And obviously if he's lethargic, his appetite will be reduced. He won't eat anything. So appetite is lost, appetite is reduced. While Marasmus child, because the visceral protein is preserved, the neurotransmitters is there, he actually wants food. So actually he's very irritable. He's crying a lot. The Marasmus child is crying a lot. He wants food. So appetite is actually increased. He wants food. There is voracious appetite. Kwashiorkor typically seen in children more than 12 months. Marasmus typically seen in children less than 12 months. As far as liver is concerned, there is going to be fatty liver in Kwashiorkor. Liver will be normal in Marasmus. Why is there fatty liver in Kwashiorkor? See, the liver stores fats in our body, right? And whenever any part of the body requires fatty acids or fat, it is transported from the liver to the rest of the body using lipoproteins. Using what? Lipoproteins. These lipoproteins are also visceral proteins. So you lose visceral protein, you lose lipoproteins. So fat is not able to be transported to the rest of the body. It starts accumulating in the liver, leading to fatty liver in Kwashiorkor. Face-wise, like I said, Kwashiorkor will have a moon face, right? Because of the edema. While Marasmus will have simian facies. It will have simian facies. So obviously Kwashiorkor, albumin is more important for survival. Neurotransmitters are more important for survivors. So prognosis is poor in Kwashiorkor while it is better or good in Marasmus. Additional feature wise, Kwashiorkor will have something called as flaky pain dermatosis and flax sign. It will have flax sign. It will have flaky pain dermatosis. What is flax sign? Flax sign is basically they will have a patch of hair which is normal, another patch which will be white because there are no enzymes, there will be no melanin synthesis. So you'll have normal hair, you will have normal hair, black hair, normal black hair. You'll have normal black hair. Then you will have a patch which is white. Then you will again have normal black hair. This is what is called as flax sign. This is what is called. And obviously these things will not be seen. These things will not be seen as far as Marasmus is concerned. This will be not be seen as far as Marasmus is concerned. For old examiners, you can write that Kwashiorkor has protein deficiency while Marasmus has calorie deficiency. You can write for old examiners who are not well versed with the current concepts. But remember, there is protein loss in both of them. There is protein loss, visceral protein loss in Kwashiorkor. There is somatic or muscle protein loss. There's somatic or muscle protein loss as far as Marasmus is concerned. All right. Now coming to SAM. SAM is what? SAM is severe acute malnutrition. SAM is what? SAM is severe acute malnutrition. What is the definition of SAM? There are three criteria for SAM. Anyone is there, you can call it as SAM. What is the first criteria? We already discussed. If the weight for length is less than minus 3 standard deviation. If it is weight for length is between -2 to -3, it is moderate acute malnutrition. If weight for length becomes less than -3, it is becomes severe acute malnutrition. Or second, I already told you, if the MUAC is less than 11.5 centimeter. Less than 11.5 SAM, 11.5 to 12.5 borderline, more than 12.5 normal. Remember this MUAC criteria is used only in 6 months to 5-year children. It's not used in children less than 6 months. Or if there is bipedal nutritional edema. If there is bipedal nutritional edema. If there is bipedal. Why? Why this bipedal nutritional edema? This is to ensure that you call a child with Kwashiorkor as SAM. See, in Kwashiorkor, because there is edema, water retention is going to be there. So weight for length can become normal. And there is water retention here. The mid-upper arm circumference can also become normal. You'll end up calling a Kwashiorkor child a normal child. You don't want that. To ensure a Kwashiorkor child is always called as a SAM child, we added this criteria. That is bipedal nutritional edema. If you have edema because of nutrition, how do you know it is nutritional edema? You'll ask history. Basically ask history. If you have edema because of nutrition, it is Kwashiorkor. It obviously means there is SAM. What is the complication of SAM? The mnemonic is simple. The mnemonic is called as shielded. Very simple mnemonic for complications of SAM. What is this mnemonic? What does S stand for? S stands for sugar. You will have hypoglycemia. H stands for you will have hypothermia. You will have infections. I stands for infection. Which infections? Remember, gram negative infections. And for this infection, we give what? We give ampicillin plus gentamicin. EL stands for electrolyte problems. What electrolyte problems can occur? You can have hypokalemia, you can have hypomagnesemia, you can have hypernatremia. These are the electrolyte problems which can occur. Hypokalemia, hypomagnesemia and hypernatremia. D stands for dehydration. Remember, for dehydration in SAM, don't give ORS, we give what? Risomol. We give what? We give Risomol. Risomol is given. Not ORS. And Risomol has higher glucose content. This has been asked multiple times. Glucose is 125 millimole per liter in Risomol. Higher glucose content as compared to ORS. And last D is deficiency. They will have micronutrient deficiency. One thing important as far as treatment part is concerned, iron is not given in first week. Right? Even if there is iron deficiency, in the first week of management, we don't give iron because it can cause free radical formation. It can increase reactive oxygen species formation, which can cause death. So we don't give it in the first week, we give it after second week. Recently there was a question which was asked on refeeding syndrome, so it's very important to understand that if in the first week of SAM management, you give a high calorie diet, what's going to occur? This high calorie diet will cause very high influx of insulin, very high amount of insulin, more calories, more glucose, more insulin. And this very high amount of insulin will cause what? This very high amount of insulin will cause potassium to go inside cell. It will cause phosphate to go inside cell. So if potassium goes inside cell, phosphate goes inside cell, you will end up having hypokalemia, will end up having hypophosphatemia. This hypokalemia and hypophosphatemia together is called refeeding syndrome. And remember, hypophosphatemia is considered the hallmark of refeeding syndrome. Hypophosphatemia is considered the hallmark of refeeding syndrome. Next we come to a very important topic, again milestones, very frequently tested milestones. As far as gross motor milestones are concerned, this is a simple stick figure which you can make and you will remember all the gross motor milestones very easily. The first, in this stick figure, you can see first line is here at the neck, second line is here at the level of trunk, third line is here at the level of knees, the fourth line is here at the level of feet. This stands for 3, 6, 9, 12. If you just remember this stick figure, this which I made, the gross motor milestones become very easy. At 3 months, it's at neck. You'll have neck control. You'll have neck or head control. At 6 months, you will have trunk control. So child will be able to sit with support. At 9 months, you will have knee control. So child will be able to stand with support. At 12 months, you will have feet control. So child will be able to walk with support. Now, at 9 months, see here. At 9 months, if you are standing with support, the prior milestone should have already been achieved. You should only be able to stand if you are first able to sit. So at 8 months, child is already able to sit without support. Child is able to sit without support at 8 months. Now, if you are able to walk with support at 12 months, walk will only start if you are able to first stand independently. So at 11 months itself, child is able to, at 11 to 12 months, given as 11 to 12 months, child is able to stand independently. At 11 to 12 months. Alright. At 11 to 12 months. Alright. And see, if at 9 months you are standing with support, how do you stand with support? You stand using the furniture. You stand with support. At 10 months, at 9 months you are standing with support. At 10 months using the furniture, the child moves sideways. This is not walking. He's moving sideways using the furniture. The sideways moving using the furniture is called cruising. So at 9 months you are standing. At 10 months, the child will start to cruise. So cruising will start at 10 months. It will start at 10 months. Two other things you should remember. At 8 months, child crawls. There is crawling at 8 months. There is creeping at 10 months. What is crawling? When a child is on all four and the abdomen is touching the ground, like a snake. In the snake, when he moves, the abdomen is touching the ground. What is creeping? When he is on all fours, abdomen is not touching the ground. So crawling is when the abdomen touches the ground. Abdomen touches the ground, creeping, abdomen doesn't touch the ground. So finally at 12 months, child is able to walk with support. After this, remember Ranbir Kapoor. Ranbir Kapoor in Ye Jawani Hai Diwani told to Naina, Deepika Padukone, Naina, ऊपर होते हैं ना एकदम पटाने की कोशिश कर रहा होता है उसको, क्या बोलता है उसको? नैना, मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, मैं उड़ना चाहता हूँ. बच्चा भी यही करेगा. Child will also do the same. मैं चलना चाहता हूँ. At 15 months, child walks. मैं दौड़ना चाहता हूँ. 18 months, child runs. मैं उड़ना चाहता हूँ. Obviously, child will not fly, but it will go up and down stairs. So at 2 years, child goes up and down stairs. But initially, he goes at 2 feet per step. He'll put both the feet on each step. Alright, 2 feet at a step or 2 feet at per time. All right. At 3 years, he's able to go upstairs at 1 feet per step. But downstairs, he still requires 2 feet. Downstairs, he still requires 2 feet because he's scared he might fall. Now, 3 for tricycle. Child is able to ride a tricycle at 3 years of age. At 4 years of age, he can go both up and downstairs. He can go both up and downstairs at single feet. At single feet. Now, 4 for 4 letters in hops. 4 letters in hops. Child hops at 4 years of age. 5 for 5 letters in skips. 5 letters in skips. Child skips at 5 years of age. So this is your gross motor milestones. Next we come to the fine motor milestones. At 3 months of age, child will try to put both the hands into midline. He puts both the hands into midline. अब हाथ को यहाँ देखेगा तो उनको देखेगा भी अगर रखें तो. When he looks at the hands, he's for the first time. Till now the hands were like this. Now he has come into the midline. He's looking at his hands for the first time. So he recognizes his hand. This is called as hand regard. So he'll also have what? He'll also have hand regard. At 4 months of age, if there's some dangling object in front of the baby, he'll try to catch it, but he won't be able to catch it. He'll either overshoot or undershoot. All right. So because he's trying to catch it both the hands, it's called bidextrous grip or bidextrous grasp. But overshooting. But there is overshooting. At 5 months, there is a bidextrous grasp, no overshooting. He will be able to catch it. At 6 months, if there is something in front of the baby, he'll be able to catch it using a single hand. But if I want to put it, I put it like this. He will hold it like this. This is called ulnar grasp. He's using the ulnar aspect of hand. So this is a unidextrous single hand grasp. This is a unidextrous grasp, but ulnar in nature. And the proper normal, the way we hold it like this, radial grasp will come at 7 months. So at 7 months, you have a unidextrous grasp, which is radial in nature. So at 7 months, when he's holding something like this, he'll be able to hold something. He'll be able to transfer this thing from one hand to another. So transfer of objects also starts at 7 months. So transfer of objects also starts at this point of time. All right. At 9 months, now he will have what is called as immature pincer grasp. At 12 months, he will have mature pincer grasp. So if he holds something like this, this is called pinch. You're pinching, this is called pincer grasp. If you're holding only between the thumb and the index finger and the thumb, it's called mature pincer grasp. But holding it like this, you're using a little bit support of your index middle finger. It's immature pincer grasp. So immature obviously will come earlier. So immature pincer grasp will come at 9 months. Mature pincer grasp will come at 12 months. Now finally at 12 months, he's holding something like this. At 15 months, he'll put this pen or pencil on paper and start to do like this. This is called as scribbling. So at 15 months, you have scribbling. At 15 months, you will end up having scribbling. Now we come to holding a pen, he'll make figures. What kind of figures will he make? So at 2 years, he's able to draw a straight line between 2 points. At 3 years, he's able to draw a circle, right? If you look closely, there is a circle inside a 3. There's a circle inside a 3. At 4 years of age, he's able to draw a cross. He's able to draw a cross. If you look closely, there is a 4 in a cross. At 4.5 years, he's able to make a square or a rectangle. At 5 years, he's able to make a triangle. If you look closely, there is a triangle inside a 5. At 6 to 7 years, he's able to make a diamond. At 9 years, he's able to make a cylinder. If you look closely, there's a 9 in a cylinder. And finally, at 11 years, child is able to make a cube. If you look closely, there's a 11 in a cube. Then you have dressing and undressing skills of the kid. Then you have something called as a dressing and undressing skills of the kid. What are the dressing and undressing skills? So at 2 years, child is able to undress with help. At 3 years, child is able to undress or unbutton without help. So obviously at 3 years, she is able to undress without help. They should be able to dress with help. So child is able to dress with help at 3 years. Child is able to dress with help at 3 years. At 4 years, child is able to button without help. And at 5 years, child is able to dress fully, which means tying of shoelaces as well. Dress fully without help. This includes tying of shoelaces as well. Dress fully without any help. Dress fully without any help. So if there was once a question asked, when is a child able to dress and undress fully without help? The answer is 5 years. Because child is able to dress fully without any help at 5 years of age. So this has been asked, when is a child able to dress fully without any help? The answer is 5 years. The answer is 5 years. The answer is 5 years. Next we come to social and language milestones. At 2 months, the first social thing that a child does is he'll look at his parents and smile. Right? This is called social smile. This is called as social smile. At 3 months, he finally starts to recognize his own mother. So child recognizes his own mother. At 6 months, 6 has 6 in it. Mirror also has 6 letters in it. Mirror also has 6 letters in it. There's going to be mirror play at 6 months. 7 has 7 in it. Anxiety also has 7 letters in it. There is going to be stranger anxiety at 7 months. At 9 months, 9 letters. Bye. 9 letters. Child waves bye-bye. Bye-bye, bye-bye. Child waves bye-bye at 9 months. Child waves bye-bye at 9 months. There's also object permanence which starts at 9 months. Object permanence also starts at 9 months. Object permanence also starts at 9 months. At 1 year of age, child is able to play a simple ball game. Child is able to play a simple ball game. At 15 months of age, there are 2 P's. What are the 2 P's? He'll point towards object and he'll point towards his own P. He'll wet his pants and then tell the parents he has wet his pants. So there are 2 P's. He will point towards objects. He'll point towards his own P or his own wet pants. At 18 months, finally, at 18 months, he will have bladder control. Child will have bladder control. So he'll be dry at day. Child will be dry at day. Second is he will have domestic mimicry. Child will have domestic mimicry. He'll mimic the parents and domestic tasks. Mother is cleaning the house. He'll also try to clean the house. All right. At 2 years of age, 2 years, 2 parallel lines. Put 2 children in a room. They will not play with each other. They'll play independently. They'll play parallelly. This is called as parallel play. When do they start playing with each other? At 3 years. So at 3 years, there is cooperative play. When they play with each other, they will share toys. So sharing of toys is also 3 years. So at 3 years, they will play with each other. This is called cooperative play. And there is going to be sharing of toys. And there is going to be what? There is going to be sharing of. There's going to be sharing of toys. At 4 years, there is a group play on role play. At 4 years, there is group play and role play. There is group play and role play. Next, we come to the language milestones. At 2 months of age, child vocalization starts. At 2 months of age, vocalization starts. At 3 months, three letters, child will coo. 4 months, 4 letters, ha ha. Child will laugh out loud. At 6 months, child will start to say ma, ba, da. So these are single syllables. You will have monosyllabic babbling. At 9 months, it will become bisyllabic. Mama, baba, dada. It will become a bisyllabic babbling. At 12 months of age, child will be able to say one meaningful word. Apart from mama, baba, dada. At 15 months, the vocabulary will be 5 words. 4 to 6 words vocabulary. And he will have jargon speech. He'll say words which don't have any meaning. At 18 months, the vocabulary is 8 to 10 words. Picture naming will start. At 24 months, 2 years, he'll be able to say 2-word sentences. Child is able to say 2-word sentences. I go, you come, he goes. In this I, you, he, these are pronouns. So use of pronouns also starts. I go. I is what? It's a pronoun. Instead of saying Aditya goes, he's saying I go. So I is a pronoun instead of Aditya, which is a proper noun. So there is use of pronouns. There is now use of pronouns. At 3 years, he knows 3 things about himself. He knows his name, age, and gender. At 4 years of age, he will be able to use 4 years, 4 letters in past tense. He will be able to use past tense. He'll be able to tell a poem. He'll be able to tell a story. He'll be able to tell a poem. He'll be able to tell a story. At 5 years of age, child will ask meaning of words. And he'll be able to say 8 to 10 word sentences. He'll be able to say 8 to 10 words. He'll be able to say 8 to 10 word sentences. Sometimes some simple one-liners are also asked. When does handedness gets established? The answer is 3 years. Your handedness gets established at 3 years. Right-left differentiation comes at 4 years. And binocular vision comes at 4 months. Binocular vision comes at 4 months. So we're done with milestones. Now we move to genetics, some important genetic disorders. Most of the time the genetic disorders will ask you to identify the genetic disorders. So I've discussed this in such a way that you're able to differentiate between 2 genetic disorders, the common in which you guys get confused. The first and most important one is your Edward and Patau. See, everyone understands Down syndrome. So I'm not going to go into Down syndrome, but Edward and Patau, people get confused. The simple way to understand the confusion and remove the confusion between Edward and Patau syndrome is simply remember per se Patau. Simply remember per se Patau. If you simply remember this, you will understand everything as far as Edward and Patau syndrome is concerned. Every feature which has per sound in it will be there in Patau. Any feature which doesn't have per sound in it will be there in Edward. So Edward is trisomy. Edward is E for Edward, E for election, E for 18th. Edward is trisomy 18. Patau is trisomy 13. Next, rocker bottom feet. Rocker bottom feet. There is no per sound. So it will be there in Edward. It will not be there in Patau. Cleft palate. There is a per sound. So it will be there in Patau. It will not be there in Edward. Holoprosencephaly. Again a per sound. If there is a per sound, it's going to be there in Patau. It's not going to be there in Edward. Fingers. Per se Patau. Patau will have polydactyly. Patau will have what? Patau will have polydactyly. What will Edward have? Edward has overlapping fingers. It has overlapping fingers. It has overlapping fingers. Kidney. Per se Patau. Kidneys in Patau will be polycystic. There is polycystic kidney. While Edward will have what? It will have horseshoe kidney. It will have horseshoe kidney. It will have horseshoe kidney. Cutis aplasia. Cutis aplasia. Per sound again. So cutis aplasia is seen in Patau. It's not seen in Edward. It's not seen in Edward. Let's see the figures. What is this? This is your rocker bottom feet resembling the rocking chair. This is your overlapping fingers. Okay? 5 fingers, not polydactyly. So this is Edward syndrome. This is Edward syndrome. What is this? You can see the cleft palate. You can see holoprosencephaly. The eyes, they are not separating out. What is holoprosencephaly? Non-separation of cerebral hemispheres. Non-separation. So cleft palate, holoprosencephaly. This is Patau. This is Patau syndrome. This is Patau syndrome. Right? So just simply remember per se Patau. If that feature has per sound in it, it will be there in Patau. If that feature doesn't have per sound in it, it will be there in Edward. Rocker bottom feet, no per sound, Edward. Holoprosencephaly, per sound, Patau. Cutis aplasia, per sound, Patau. Polycystic kidney, Patau. Right? Cleft palate, Patau. E for Edward, E for 18. Patau, 13. Patau is 13. Patau is 13. Patau is 13. Next we come to Turner and Noonan syndrome. So why does Turner syndrome occur? Turner syndrome occurs, we all know occurs because of monosomy X XO. But Noonan syndrome, remember, it's an autosomal disorder. In fact, it's an autosomal dominant disorder because of PTPN11 mutation. Because of PTPN11 mutation. and hence it can be seen in both males and females. It can be seen in both males and females. Then why I'm comparing to? Where am I comparing to? I'm comparing to because the physical features of Turner and Noonan are same. Physically means phenotypically. The physical appearance is same. The cause is different. Turner's occurs because of monosomy X, XO. Noonan occurs because of PTPN11 mutation. It occurs because of PTPN11 mutation. What is the physical appearance which is the same as far as Turner and Noonan is concerned? Both will have the 3 Ws and short stature. Both will have the 3 Ws plus short stature. What are these 3 Ws plus short stature? What are these 3 Ws? Both will have widely spaced nipples. Both will have widely spaced nipples. Both will have wide carrying angle. Right? Both will have this. Both will have this webbed neck. Both will have this webbed neck. Both will have this. And both will have short stature. So this physical appearance is same in both Turner and Noonan. But Noonan occurs because of PTPN11 mutation. That's the genotype. Turner occurs because of XO. Turner only females, right? But Noonan can occur in both males and females because it is autosomal dominant in nature. Then there are certain other differences also. In Turner, the most common heart defect is bicuspid aortic valve. In Noonan, the most common heart defect is pulmonary stenosis. Remember, IQ is normal in Turner, IQ is decreased in Noonan. And Turner, because of monosomy X, we all know they have streak ovaries, they have infertility. There is no fertility, they have streak ovaries. Here there is subfertility, less fertility than normal, but fertility is present. That's why it's autosomal dominant. That's why the parents will be able to transmit from one generation to another. Males with Noonan males who have Noonan syndrome, they have cryptorchidism. They have what? They have undescended testes, that is cryptorchidism. Right? So if a male child, remember, comes with these things, male child comes with widely spaced nipples, wide carrying angle, web neck, it is Noonan syndrome, because Turner will always be girls. Turners will always be what? It will always be girls. It will always be girls. Next, you have Diarrhea syndrome. Remember, Diarrhea syndrome is a microdeletion syndrome where there is defective formation of 3rd and 4th pharyngeal arches. Where there is defective formation of 3rd and 4th pharyngeal arches. And what is the deletion? It is 22q11 deletion. It is 22q11 deletion. It is also known as catch-22 syndrome because of the problems that occur here. What are the catches? You will have cardiac defects. C stands for cardiac defects. You will have abnormal facies. You will have thymic aplasia because thymus is formed from the 3rd and 4th pharyngeal arch. You will have thymic aplasia. What does 3rd and 4th pharyngeal arch form? It forms thymus and it forms parathyroid gland. So thymus and parathyroid gland will not be there. So the T is the thymic aplasia part. And because there is thymic aplasia, there will be loss of cell-mediated immunity. There will be no T cells. There will be no T cells and there will be loss of cell-mediated immunity. So you'll have recurrent infections in these individuals. Next C is you will have cleft lip or cleft palate. NH is you will have hypocalcemia. Why is there hypocalcemia? Because there is no parathyroid gland. If there is no parathyroid gland, there will be no PTH. You will have hypocalcemia, which can cause tetany, which can cause seizures. And 22 stands for the 22q11 deletion. It stands for the 22q11 deletion. It stands for the 22q11 deletion. Next, two other syndromes, very contrasting syndrome. This is the Prader-Willi syndrome, PWS. This is the Angelman syndrome. Why does Angelman occur? Angelman occurs because of the angle. Who are angels? Your mothers are angels. Who are angels? Your mothers are angels. Both are genomic imprinting disorders. Both are examples of what? Genomic imprinting disorders. In Angelman syndrome, there is deletion of active maternal gene. On 15q11.13. But in Prader-Willi syndrome, PWS, there is deletion of active, P for Prader-Willi, active paternal gene on 15q11.13. On 15q11.13. Angelman syndrome is also called as happy puppet syndrome. Why are they called happy puppet? Because they have this inappropriate laughter, and they have the puppet part is because they have ataxia. Because they have ataxia, and they will have fallen IQ as well. They will have fallen IQ as well. So they will be very happy, inappropriate laughter. They will have ataxia. They will have fallen IQ. Prader-Willi looks like this. They will be obese. They will have hyperphagia, causing obesity. They will have short stature. They will have short stature, and they will have hypogonadism as well. And obviously there will be fall in IQ also. There will be fall in IQ also. Chote, mote or buddhu. Chote, short stature, mote, hyperphagia, obesity. Buddhu, low IQ. Alright, low IQ. So this is your Prader-Willi syndrome. This is your Prader-Willi. Both are examples of genomic imprinting disorders. Both are examples of genomic imprinting disorders. Now we are going to discuss some important congenital infections. Now we are going to discuss some important congenital infections. We are going to discuss some important congenital infections. First, we are going to discuss congenital toxoplasmosis. This is characterized by chorioretinitis, calcifications, and hydrocephalus. Remember, the calcification in toxoplasmosis, they are diffuse calcification. They are what? They are diffuse calcifications. Congenital rubella syndrome, very characteristically, again, very frequently asked, it is characterized by a triad of patent ductus arteriosus, very frequently asked, patent ductus arteriosis, sensory neural hearing loss, and cataract. Congenital CMV infection is characterized by a triad of CMV. C stands for chorioretinitis. M is microcephaly. V is periventricular. Here the calcifications are periventricular in nature. Periventricular calcifications. Remember, 90% cases are asymptomatic. But even these asymptomatic cases later in life will have sensory neural hearing loss. Even these asymptomatic cases, 2-3 years down the line will have sensory neural hearing loss. In fact, it's the most common cause of non-syndromic SNHL. It is the most common cause of non-syndromic SNHL. How do you detect it? You will do urine CMV PCR. The method of detection, the choice of detection is, we prefer doing a urine CMV PCR. Till 3 weeks. After 3 weeks, we prefer blood CMV PCR. And what is the treatment? Treatment is gangicyclovir. Next, you have congenital syphilis. Congenital syphilis is characterized by a triad of बुरा ना देखो, बुरा ना सुनो, बुरा ना बोलो. So बुरा ना देखो, you will have interstitial keratitis. You will have problem in the eyes. You will have interstitial keratitis. बुरा ना सुनो, you will have eighth cranial nerve palsy. बुरा ना बोलो, you will have Hutchinson teeth, which are basically these notched incisors. You will have Hutchinson teeth. Which are basically this notched incisors. Apart from this, you can have this destruction of nose. This is called as saddle nose. So this completes a congenital infection, very frequently tested. Another very frequently tested part, congenital infections. We've done most of the stuff. Now we're moving towards a little bit topics of neonatology and a little bit of systemic pediatrics. You guys tell me, what is this? What is this showing? What is this diagram? What is this chest X-ray showing? 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 Tell me. Tell me, what is this chest X-ray showing? Exactly. So very commonly asked question. You can see the intestinal loops, they're going into the chest. Why are they going into the chest? Because the diaphragm is not there. So the intestinal loops are moving into the chest. This is called as, this X-ray is denoting what? This is congenital. This is congenital diaphragmatic hernia. Remember, the most common site is left posterolateral. Remember, the most common site is left posterolateral. Most common type is Bogdalic. And why is it problematic? Because the intestinal loops, when they come into the chest, they don't allow the lungs to grow in utero. If the lungs have not grown in utero, there is going to be pulmonary hypoplasia. So even if you do surgical correction, the pulmonary hypoplasia will not resolve. Remember, the most important cause of death. What is the cause of death? It is almost always pulmonary hypoplasia. 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 Alright, that's another very important thing in CDH. You should remember that bag and mask is contraindicated, because if you do bag and mask ventilation, air will go into the intestine. From the mouth, it will go into the intestine. Intestines will expand. They'll further compress the already hypoplastic lungs. So always remember that bag and mask ventilation. That bag and mask ventilation is contraindicated in congenital diaphragmatic hernia. Next, you have transient tachypnea of newborn. Remember, transient tachypnea of newborn is seen in term and late preterm babies. And what is the most important risk factor? Remember, the most important risk factor is being born via LSCS. Other important risk factors include infant of diabetic mother and a male child. What basically happens in transient tachypnea of newborn is that in a normal vaginal delivery, this is vagina, this is the baby, there's a lot of squeezing involved. The squeezing causes a lot of sympathetic release, a lot of adre, noradre. This lot of nadre and noradre stimulates a channel called ENaC, a sodium channel in the lungs. So as soon as the baby is born, the lungs, which contain a lot of fluid, the ENaC channel will reabsorb all this fluid, making the lungs dry. Right? So this is what happens in a normal vaginal delivery. In a LSCS, in a cesarean section, nothing of this sort will absorb. So that ENaC channel, that sodium channel, is not activated. So fluid will stay in the lungs for a little bit. As a result, because there is fluid in the lungs, there's going to be a little bit of tachypnea, there's going to be a little bit of respiratory distress. Will it be permanent? Of course not. Over a period of time, it will resolve on its own. That's why it's called transient tachypnea of newborn. So what is the cause? It is a lack of sympathetic stimulation. Of the sodium channel in the lungs, leading to retention of fluids in lungs. That causes a tachypnea. What will you see on chest X-ray? This, very characteristically, this fluid will be here in the form of you will see fluid in horizontal fissure. This is called as fluid in horizontal fissure. Very characteristically see fluid in horizontal fissure. What is the treatment? Like I said, it is transient. It will self-resolve in 72 hours. Right? So nothing is required, only supportive care. Maybe they require a little bit of oxygen, but nothing extraordinary. Right? Right? It will self-resolve. As the body reabsorbs that fluid, the tachypnea will go. That's why it's called transient tachypnea. Next, you have respiratory distress syndrome. Remember, respiratory distress syndrome is seen in preterm babies less than 34 weeks. Why? Because there is no surfactant. What is the cause? It is lack of surfactant. And that lack of surfactant will cause what? It will cause alveolar collapse. The LS ratio is characteristically less than 2. What is the LS ratio? L stands for lecithin. S stands for sphingomyelin. And lecithin, remember, is the main component of surfactant. Lecithin is the main component of surfactant. So LS ratio low tells you that low surfactant, higher chance of having respiratory distress syndrome. What do you see on chest X-ray? So there is all the alveolar collapse, the chest X-ray will be a whiteout. There's going to be complete whiteout. So you'll see a complete whiteout. But remember, the trachea will still have the air. The bronchus will still have the air. So if you look closely, you will see that there is air in the trachea, there is air in the bronchus. This is called as air bronchograms. This is called as air bronchograms. So you'll see complete whiteout with air still in the trachea, air still in the two main bronchus, left and right bronchus, which is called as air bronchograms. How do you treat respiratory distress syndrome? You don't want to treat it, you want to prevent it. You want to make the lungs more mature, for which you give antenatal steroids. Which antenatal steroids can you give? You can either use betamethasone or you can use dexamethasone. The dose of betamethasone is ber se beta, ber se 12. So you give 12 mg twice 24 hours apart. If you want to give DEXA, you will give 6 mg 4 times 12 hours apart. This is how you can prevent. It will improve lung maturity. It will improve lung maturity, antenatal steroids. But even if, let's say, a child is born with RDS, initially you can start the child on CPAP. If, let's say, the CPAP fails, then you can give exogenous surfactant. The method to give this exogenous surfactant is called INSURE. It's called INSURE. What does INSURE stand for? IN stands for intubate. SUR is surfactant. E stands for extubate. E stands for extubate. E stands for extubate. E stands for extubate. This is the way. We will intubate, we will give surfactant, we will extubate the baby. And another very important thing in neonatology is your APGAR score. What are the components of APGAR score? These are your appearance, pulse, grimace, activity, and mnemonic is APGAR itself. A stands for appearance, which is basically color. P stands for pulse, which is basically your heart rate. G stands for grimace. A stands for activity. R stands for respiratory efforts. R stands for respiratory. R stands for respiratory efforts. It stands for respiratory efforts. So we'll give a score of 0 if the child is fully blue. We'll give a score of 1 if there is acrocyanosis. That the body is pink, but the extremities are cyanosed. And we'll give a score of 2 if the baby is fully pink. Give a score of 2 if the baby is fully pink. As far as heart rate is concerned, you'll give a score of 0 if the heart rate is 0. You'll give a score of 1 if the heart rate is less than 100. You'll give a score of 2 if the heart rate is more than 100. Grimace. You'll give a score of 0 if there is no grimace. If there is some grimace, you'll give a score of 1. How do you assess for grimace? You put a nasal cannula and you look for the response. If you put a nasal cannula and the child sneezes because of the irritation, it's called full grimace. So if the child sneezes, you'll give a score of 2. You'll give a score of 2. Activity is basically how much flex the baby is. If there is, if the baby is fully limp, there is no tone. Activity is the same as tone. If the baby is limp, we'll give a score of 0. If there is some flexion or partial flexion, you'll give a score of 1. If there is full flexion, you'll give a score of 2. You'll give a score of 2. As far as the respiratory efforts are concerned, you'll give a score of 0 if there are no efforts, child is apneic. If there are some efforts, you'll give a score of 1. If the child is crying, you'll give a score of 2. Full efforts, you'll give a score of 2. Alright, so this completes the most important topics of neonatology. Remember that resuscitation you can do on your own. That's one topic I'll advise you to do on your own. Now we'll discuss about the IMNCI management of dehydration, IMNCI management of pneumonia, a little bit of cystic fibrosis. Alright, so we'll discuss about diarrhea. What is the most common cause of diarrhea in children? Remember, very commonly asked, it is rotavirus. It is rotavirus. What is the bacterial most common cause of diarrhea in children? It is E. coli. If a child has HIV, the diarrhea is usually caused because of atypical organism. It is usually caused because of atypical organisms. It's usually caused because of atypical organisms. As far as management of diarrhea is concerned, there are two things that you have to take care of. You have to take care of the dehydration, because which is occurring because of diarrhea, and you have to give zinc. Why do you give zinc? Zinc decreases diarrheal duration, improves epithelial integrity. How much zinc needs to be given? That depends upon the age of the child. The child is less than 6 months, you will give 10 mg daily for 2 weeks. You'll give 10 mg daily for 2 weeks. If the child is more than 6 months, you will give 20 mg daily for 2 weeks. How do you manage dehydration? For dehydration, what do? You first classify the dehydration into 3 categories. You'll clinically assess the child and classify his dehydration into no, some or severe dehydration. If you classify the child as no dehydration, the approximate fluid, the water that he has lost because of diarrhea, is going to be less than 50 ml per kg. It's going to be less than 50 ml per kg. In some dehydration, he would have lost somewhere around 50 to 100 ml per kg. And in severe dehydration, he would have lost at least 100 or more ml per kg. He would have lost at least 100 ml per kg, or maybe even more. Now, how do you classify whether there is some or severe or no dehydration? Use 4 categories. You use 4 criteria: the consciousness of the child, the thirst of the child, the skin pinch of the child, and the eyes of the child. If there is no dehydration, the child will be normal in consciousness. He will be active, alert. In some dehydration, because lost some water, now he'll be irritable. He wants water. That's why he's irritable. So in some dehydration, child is going to be irritable. In severe dehydration, because he has lost a lot of water, child will now become lethargic or comatose. He'll be lethargic or comatose. Thirst. In normal no dehydration, obviously child thirst is going to be normal. In some dehydration, he was irritable because he wants water. So thirst is actually increased. Thirst is increased. He drinks eagerly. Child will drink eagerly. In severe dehydration, because the child is lethargic, there is no activity, the child is lethargic, so he won't be able to drink. Even though he has a lot of dehydration, there is severe dehydration, he is unable to drink water because he is lethargic. Child is unable to drink. Child is unable to drink. Skin pinch will be normal in no dehydration. Skin pinch will be a little delayed. There is some delay. In some dehydration, it is very delayed. In severe dehydration, eyes will be sunken in no dehydration. Eyes will be very sunken. Sorry, eyes will be normal in no dehydration. Eyes will be sunken in some dehydration. They will be very sunken in severe dehydration. So how do you manage this no, some and severe dehydration? Let's understand. We use 3 different plans: plan A, plan B, and plan C. We use plan A for no dehydration. See, if there is no dehydration, you don't have to rehydrate the child. So what is the goal? The goal is simple. With every passing loose stool, he will lose some extra water. So he might go from no to some dehydration. You don't want that. So anytime he has a loose stool, you replace whatever water he has lost in that loose stool. So goal of no dehydration is simple. You replace ongoing stool losses. Anytime he has a loose stool, he loses some water, you replace that. That's a simple goal. How do you do that? That every time he has a loose stool, you will give him 10 ml per kg ORS with each loose stool. So every time he has a loose stool, he lost water, you replace that loose stool water 10 ml with 10 ml per kg of ORS. Let's say there was a 10 kg child, every time he has a loose stool, 10 into 10, you gave him 100 ml of ORS to replace whatever water he lost in that loose stool. Now this ORS, what does it contain? This is the WHO formation of ORS. It contains sodium, glucose, potassium, chloride, and citrate. Sodium and glucose both are 75 millimole per liter. They are in a 1:1 ratio. This stimulates sodium absorption via SGLT1 channel. This promotes sodium absorption via SGLT1 channel. Potassium is 20, chloride is 65, citrate is 10, so that the total is 245. Total is 245. Remember, what does Risomol have? Which I told you is used as far as, which is used as far as SAM is concerned. Risomol also has sodium, it also has glucose, it also has potassium, it has chloride, it has citrate, it also has magnesium. Sodium is lower because there was hypernatremia, it is 45. Glucose is higher because there was hypoglycemia. Potassium is also higher because there was hypokalemia, so potassium is 40. Chloride is 75, citrate is 7, and magnesium is 3. So this is what is there in Risomol. This is what is there in Risomol. The total osmolality comes to 295 to 300. The total osmolality comes to 295 to 300 millimole per liter. In some dehydration, see in some dehydration, what was the water loss? In some dehydration, baby has lost some water between 50 to 100 ml per kg. So you need to rehydrate him. How much? Between 50 to 100 ml per kg. So use right in the middle, 75. You will give him 75 ml per kg. What? He's drinking? Give him ORS. We'll give him 75 ml per kg ORS over 4 hours. This 75 ml per kg ORS can be given orally, or it can also be given via NG. Can be given via NG. Now, 75 ml per kg will take care of his some dehydration. Now he has become normal. Now he has a loose stool. He lost other water. So you'll replace that water again. So you will rehydrate the child by this. You will rehydrate the child by this, and you will keep on replacing ongoing fluid losses. How much? Same. 10 ml per kg ORS with each loose stool. With each loose stool. With each loose stool. In severe dehydration, now child is lethargic, not able to drink. So you have to use IV fluids. How much IV fluids? He has lost how much IV water? 100 ml per kg he has lost. You have to give 100 ml per kg of IV fluid. Which IV fluid? We prefer RL with 5% dextrose over RL over NS. Anyone can be given, but the best fluid is RL with 5% dextrose. How much needs to be given? 100 ml per kg needs to be given. This is given in two different aliquots or two different parts. There's an initial 30 ml per kg part and a remaining 70 ml per kg part. 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 The initial 30 ml per kg part is given over half hour if the child is more than 1 year. The remaining 70 ml per kg is given over 2.5 hours. So that the entire 100 ml per kg, so that the total 100 ml per kg is given over half plus 2.5 hours, that is only 3 hours if the child is more than 1 year. Child is less than 1 year, you have to give it slowly. The first 30 ml per kg is given over 1 hour, the remaining 70 ml per kg is given over 5 hours, so that the entire 100 ml per kg is given over 1 plus 5, that is 6 hours. 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 I'll summarize. In no dehydration, what do we use? We use ORS. What is the amount? We give 10 ml per kg with each loose stool. With each loose stool. No time point. In some dehydration, we again use ORS, which can be given orally or via NG. We give 75 ml per kg over 4 hours. Over 4 hours. In severe dehydration, we use IV fluids. How much? 100 ml per kg. Given over 3 hours if the child is more than 1 year. Given over 6 hours if the child is less than 1 year. The child is less than 1 year. Child is less than 1 year. Child is less than 1 year. Next we have maintenance fluid. How do you calculate maintenance fluid? We use a formula called holiday cigar formula. Which simply states if the child is between 1 to 10 kg, the first 10 kg, maintenance fluid is calculated as 100 ml per kg. What is maintenance fluid? It's the fluid that you required on a daily basis. Right? रोज का दिन का जो पानी पीते हैं ये maintenance fluid होता है. It has no effect on dehydration. सब में सेम देना होता है, चाहे नो हो, सम हो या सेवेयर हो. ये वो पानी है, इसका डिहाइड्रेशन से कोई लेना देना नहीं है. ये वो पानी है जो आपको दिन में पीना होता है. Simple. So first 10 kg in children it is calculated as 100 ml per kg. Given over obviously दिन में दे रहे हो 24 hours. The child is between 11 to 20 kg. The first 10 kg is still calculated as 100 ml per kg, but between 11 to 20 kg, it is calculated as 50 ml per kg. Again in 24 hours. And beyond 20 kg, every kg is calculated as 20 ml per kg over 24 hours. Let's see, for example, there is a 17 kg child. So first 10 kg, we'll use 100 ml per kg. So 10 into 100, that is 1000 ml. For the remaining 7 kg, 17 kg, between 11 to 20, we'll use 50 ml. So 7 into 50, 350 ml. This maintenance fluid will be added all 1350 ml. So for a 17 kg child, what is the maintenance fluid? The answer is going to be 1350 ml in 24 hours. Daily maintenance. Alright, daily maintenance fluid. Alright, daily maintenance fluid. Alright, daily maintenance fluid. Alright, daily maintenance fluid. Alright. Next we come to cystic fibrosis. Next we come to cystic fibrosis. Very important topic. Why does cystic fibrosis occur? Because there is a problem in which gene? There is a problem in CFTR gene which is present on chromosome 7, and it functions as a chloride conductance channel. The most common mutation in cystic fibrosis in the CFTR gene is what is called as delta F508, which stands for deletion, F stands for phenylalanine, and 508 is the amino acid position. So the phenylalanine which is there at the 508th amino acid position gets deleted. This is the most common mutation. Now, why does this chloride mutation, chloride conductance channel mutation, lead to cystic fibrosis? Let's understand. Remember, the function of the CFTR protein, this chloride conductance channel, is same throughout the body except sweat glands. In sweat glands, the function is different. Rest everywhere in the body, the function is exactly the same. The function is exactly the same. In airways and pancreas, the most common organs which are involved in cystic fibrosis, the function of the CFTR protein is it transports chloride from inside the cell into the lumen. Now, if chloride comes into the lumen, it will attract a lot of sodium. It will attract a lot of sodium. So now you have sodium and chloride both in the lumen. If sodium and chloride are both in the lumen, this will attract a lot of what? This will attract a lot of pani, this will attract a lot of water, this will attract a lot of water into the lumen. So if water comes into the lumen, the secretions will become watery. This will cause secretions to become watery. This is what happens normally. What will happen in cystic fibrosis? Whatever I told you will not occur. Whatever I told you will not occur. So this chloride will not come. This sodium will not come. And as a result, this water won't come. As a result, secretions won't be watery. They'll be very, very thick. They'll be very, very viscous. You'll end up having very, very thick secretions. And these thick secretions are the core problem with cystic fibrosis. If you have thick secretions in the lungs, they won't be able to come out. You will have recurrent infections. You have thick secretions in pancreas. The enzymes won't come out. You will have pancreatic insufficiency. You won't absorb fat. You don't absorb fat. You will have fat malabsorption. Fat malabsorption, fat in stool, steatorrhea. Vitamin A, D, E, K, which are fat-soluble vitamins, their deficiency will occur. Right? You have thick secretions in the gut, constipation. You put a lot of pressure. Rectum comes out. Rectal prolapse. So everything in cystic fibrosis is why? Because there are thick secretions. Thick secretions, lungs, LRTI, pancreas, pancreatic insufficiencies, gut, constipation, rectal prolapse. That is the reason why cystic fibrosis is also called as mucoviscoidosis. Another term for cystic fibrosis is mucoviscoidosis. Secretions, mucosal secretions have become very, very viscous, and that is causing all problem. That is causing all the problems. The only place where the function is different, I told you, is sweat glands. In sweat glands, CFTR helps in absorption of chloride. It helps in absorption of chloride. So if cystic in cystic fibrosis, this will not take place. As a result, this chloride will stay in lumen. This will cause increased sweat chloride. This will cause increased sweat chloride, which is used for diagnostic purpose, this is used as a diagnostic criteria, is used for the diagnostic purpose. This is used for diagnostic purpose. So what will be the clinical features? In the airway, I told you, thick secretion, recurrent LRTI, which will cause bronchiectasis. Most common is staph. Most common organism is Staph aureus, followed by Pseudomonas. You will have exocrine pancreatic insufficiency. There will be no pancreatic enzymes. They will not be able to come out. This will lead to fat malabsorption. This will lead to what? This will lead to fat malabsorption. And this fat malabsorption will cause what? It will cause ADEK. It will cause ADEK deficiency. Right? Fat will come in stool, which is called steatorrhea. Intestine, you will have rectal prolapse, you will have obstruction syndrome. And sometimes they also have congenital absence of vas deferens. Vas deferens is not there. If vas deferens is not there, the sperms will not be able to come into the semen. So there will be azoospermia, obstructive azoospermia. There is going to be obstructive azoospermia. How do you make a diagnosis? Increase sweat chloride. Sweat chloride more than 60. At least on 2 occasions. If this fails, you can do a diagnosis using CFTR mutations. 2 or more known mutations in the CFTR gene. If this fails, you can look for abnormal nasal potential difference. You can look for abnormal nasal potential difference. How do you treat it? How do you treat cystic fibrosis? You will do chest physiotherapy. You'll do a lot of thumping like this. This will cause the expectorations to come out, the secretions to come out, decreasing LRTI. You'll do pancreatic enzyme replacement. And 2 new drugs you should remember. One is called ivacaftor, other is called lumacaftor. Ivacaftor increases chloride conductance. Lumacaftor improves protein folding. It improves CFTR protein folding. So ivacaftor will cause more chloride to be secreted from the CFTR channel. Lumacaftor will make the CFTR protein formation normal, improving the CFTR protein folding. Okay. Now we come to IMNCI management of pneumonia. IMNCI management of pneumonia. IMNCI says anytime a child comes to you with any form of respiratory distress, you classify his respiratory distress into 3 categories: no pneumonia, pneumonia, and severe pneumonia. When do you say it is no pneumonia? When there are no features of pneumonia. There is only cough and cold. Wheezing might be there, plus minus. So if there is no pneumonia, there is no need to give antibiotics. What will you give? Only soothing measures. Vicks ki goli lo, khich khich dur karo. That's it. Only soothing measures are required. Right? Warm water, honey infused water, Vicks, like that. Only soothing measures. Because there is no pneumonia, what's the point of giving antibiotics? If wheeze is there, you can give salbutamol. If wheeze is present, you can give salbutamol. Then what is pneumonia? Pneumonia can be of 2 types. First, either you see chest indrawing. If you see chest indrawing, it is automatically pneumonia. Or you see fast breathing. What is fast breathing? The child is breathing fast. How fast? There are cutoffs. For less than 2 months, if the child's respiratory rate is more than 60, you will say there is fast breathing. You will say there is fast breathing pneumonia. Between 2 to 12 months, the cutoff is 50. For more than 12 months, the cutoff is 40. Anytime the respiratory rate is more than this, it automatically becomes pneumonia. If there is pneumonia, you need to give antibiotic. So here you will give oral amoxicillin for 5 days. You will explain the danger signs to parents and send them home, because oral amoxicillin can be given at home. You will explain the danger signs. And you will ask for follow-up after 2 days to see whether there is improvement or whether it has worsened. We'll ask for follow-up in 2 days. Now, what is severe pneumonia? Severe pneumonia is if you see stridor in a calm child, if you see stridor in an otherwise calm child, if there is stridor in an otherwise calm child, or if there are any danger signs. What could be the danger signs? High-grade fever. Temperature more than 38.5 degrees Celsius. High-grade fever. Child is lethargic. Child is having seizures. Or SpO2 has fallen. All these are danger signs. Severe pneumonia, remember, cannot be managed at a primary health center. You need to refer to a higher center. So here the management is refer after. Refer after first dose of IV antibiotic. Okay. Now, next, these are some chest X-rays which are very frequently tested. Snowman or figure of 8 appearance, seen in which condition? TAPVC. Boot-shaped heart, seen where? Tetralogy of Fallot. Box-shaped heart, seen where? Epstein anomaly. And this egg on string appearance, seen where? It is seen in TJ. This 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 is seen in TJ. Alright. Now, tetralogy of Fallot, what are the 4 components of tetralogy of Fallot? Remember, the main component of tetralogy of Fallot is always pulmonary stenosis. Because there is pulmonary stenosis, the right ventricle pumps harder and harder and harder. This leads to the second component of tetralogy of Fallot, that is right ventricular hypertrophy. Now, because the blood wants to go from right ventricle into the pulmonary artery, but it is unable to go because of pulmonary stenosis, this leads to the third component of tetralogy of Fallot. There is a huge VSD. That is the third component. There is a huge VSD. And this huge VSD allows the blood to go from right ventricle into the left ventricle, leading to right to left shunt. This huge VSD allows for the right to left shunt, and that causes the cyanosis, Because the VSD is huge, the aorta doesn't seem to arise from the left ventricle, it arises from the common left and right ventricle. That is called the fourth component. There is going to be overriding of aorta. There is going to be overriding of aorta. Remember, cyanosis is directly proportional to pulmonary stenosis, because more the pulmonary stenosis, more the right ventricle hypertrophy, less blood will go into the pulmonary artery, more blood will go from right ventricle to the left ventricle, leading to more cyanosis. But remember, murmur is inversely proportional to the amount of pulmonary stenosis. Why? Imagine two scenarios. Scenario A, scenario B. Here there is pulmonary stenosis, here there is pulmonary stenosis. In scenario A, blood is able to at least go from the right ventricle to into the pulmonary artery. But there is stenosis, this causes murmur. In scenario B, blood will be unable to go into the pulmonary artery. If there is no blood flow, how will you hear a murmur? So when the stenosis is complete, you can't hear a murmur. You cannot hear a murmur because there is no blood flow. So remember the murmur in tetralogy of Fallot is inversely proportional to the amount of stenosis, while cyanosis is directly proportional to the amount of pulmonary stenosis. Alright. Next we'll do a rapid fire images. Next we'll do just some rapid fire images. Just keep on telling me. This is what? This is diphtheria. Remember, diphtheria toxin inhibits elongation factor 2. The complication which leads to death in diphtheria is myocarditis. Right? What is the vaccine? The vaccine is DPT vaccine. This is diphtheria. What is this? This is strawberry tongue. Where is it seen? It is seen in Kawasaki disease. What is the criteria for Kawasaki disease? 4 out of 5. What are these 4 out of 5? C. Conjunctivitis. Remember, it is non-purulent conjunctivitis. There is no pus. R. Rash. E. Extremity changes. There will be periungual edema. Extremity changes. A. Adenopathy. Usually there is unilateral cervical adenopathy. And M is mucosal changes like strawberry tongue. What is this? This is an ultrasound image of congenital hypertrophic pyloric stenosis. And in congenital hypertrophic pyloric stenosis, you can see what? The length of the pyloric muscle becomes more than 16 mm. Remember, the investigation of choice in congenital hypertrophic pyloric stenosis is always ultrasound. And the characteristic metabolic abnormality in CHPS is metabolic alkalosis with paradoxical aciduria. This is a characteristic abnormality. What is this? This is Hirschsprung disease. This is an X-ray of Hirschsprung disorder. Most common site, rectosigmoid. Why does it occur? There is a failure of neural crest cell migration. There is no neural crest cells. That leads to lack of Meyntrich plexus and defective contractions. So this area, it won't have contraction, so it collapses. And the proximal part keeps on getting dilated. Investigation of choice, remember, is what? Rectal biopsy. It is rectal biopsy. I'm not going to explain. This is a rapid fire round. This is a rapid fire round for your revision. What is this? This is omega shaped epiglottis seen in laryngomalacia. And laryngomalacia, remember, is the most common cause of stridor in children less than 1 year. This is what? This is omega shaped epiglottis. This is omega shaped epiglottis. This is what? Omega shaped epiglottis. This is omega shaped epiglottis. What is this? This is the fifth disease, also known as erythema infectiosum. Caused because of parvovirus. Caused because of parvovirus B19. Caused because parvovirus B19 is also known to cause aplastic crisis. It decreases RBCs. It causes non-immune hydrops and it causes non-erosive arthropathy also. It causes non-erosive arthropathy also. What is this? This is measles. Most common complication of measles, otitis media, secondary bacterial infection of the. What is the most common cause of death? Pneumonia, secondary bacterial pneumonia. What is the late complication? SSP, which can lead to myoclonic jerks. What is the treatment of measles? We give vitamin A. What is the dose? The same dose I told you on day 0, 1 and 14. Why vitamin A? Because it increases cell-mediated immunity. And in measles, cell-mediated immunity is decreasing. That's why there is secondary bacterial infection. What is the vaccine? MMR. What is the strain? Edmonston Zagreb. What is this? Mumps. In children, it causes parotitis. In adult, it causes orchitis, which can lead to decreased sperm production. Although infertility is not seen, but decreased sperm production is seen. Vaccine, again MMR. What is the strain? Gerald-Lynn strain. The strain is called as Gerald-Lynn strain. The strain is called as Gerald-Lynn strain. Strain is called as Gerald-Lynn strain. What is this? No brain. This is anencephaly. This is anencephaly. There is failure of anterior neuropore closure. When? And this has been asked. During the 4th week period of gestation. During the 4th week period of gestation. For prevention, we give folic acid. For prevention, we give folic acid. It's a neural tube defect. What are the risk factors? If the mother is taking valproate or phenytoin. If the mother is taking valproate or phenytoin, mother has diabetes, mother has fetal Hydantoin syndrome, fetal alcohol syndrome, all these are risk factors. What is this? This is an image of congenital hypothyroidism. You can see the protruding tongue. You can see the coarse facies. You can see the abdominal wall defects and umbilical hernia. Along with that, they will have hypothermia. Along with that, they will have prolonged jaundice. They will have lethargy. They will have lethargy. So this is what? This is congenital hypothyroidism. This is what? This is congenital hypothyroidism. This is how it looks like. What is this? What kind of appearance? Starry sky appearance. Seen where? Characteristically seen in Burkitt lymphoma, which presents with like this jaw swelling. What is the translocation? Translocation 814, which involves c-MYC, on chromosome 8. What is the virus? EBV virus. What is the virus involved? EBV virus. What is the virus involved? EBV virus. What is this sign? Gower sign. Where is it seen? Duchenne muscular dystrophy. And Duchenne muscular dystrophy also remember has calf pseudohypertrophy. Has calf pseudohypertrophy. Last thing, what is this sign called as? Steeple sign. Where is it seen? Laryngotracheobronchitis or croup. What is the most common cause? Parainfluenza virus. What do we give? What is the drug of choice? It is dexamethasone. Followed by adrenebulization. What is this? Thumb sign. Where is it seen? Epiglottitis. Where is it seen? Epiglottitis. What is the most common cause? Nowadays it is streptococcus. Earlier it used to be, when vaccination was not there, H. influenzae. They will have tripod position. And remember, drug of choice is 3rd gen cephalosporin. Drug of choice is third gen cephalosporin. Drug of choice is third gen cephalosporin. All right. So we have done a very rapid fire round also. With this, we have discussed a lot of things. I hope you enjoyed the topic. I hope you enjoyed the discussion. You will revise all these sessions and you should be able to get 60 to 70% of the questions correct. All right. Thank you. You can join the channel. On this channel, the annotated PDF will be there. Join this channel, take a screenshot. On this, the annotated PDF is going to be there. All right.